Hello, everyone. Welcome, welcome, welcome. Welcome to the 2020 AMCHP virtual conference. We are so excited for you to join us today. It's been quite a year thus far, but I'm so proud of our public health and MCH community. Thank you all for your leadership and your sacrifice really during these difficult times. And although things have been challenging for us and for the country as we battle COVID-19, I can honestly say that we'd be in a much worse place if it was not for you. So thank you all so much. Thank you also to our attendees, exhibitors, and sponsors for being here. Without your continued support, none of this really would be possible at all. This year's conference didn't quite happen as we planned for it to, but like so many other things these past several months, we've had to be flexible, persevere, and find new and innovative ways to do things. This is our first virtual offering, and we are excited about the opportunity for us to still meet and share some amazing content. We invite you to participate in meaningful discussion and to network. I'm glad to be with you today, and I'm so glad that you were able to join us. Now, let's take a pause for a moment and take time to acknowledge and appreciate that we made it to this moment. Please give yourselves a virtual round of applause. I'm so looking forward to spending the next few days with you all. In my past 2 years in my leadership capacity as president and president-elect, we've been presented with unique opportunities to lead the maternal and child health community, and some that will be highlighted over the next few days. We've made an intentional effort to engage with and involve youth in our work. Their voice is so critical to our success. We are actively identifying ways to engage them in our AMCHP leadership roles, and we encourage you to do the same in your states and your organizations. In fact, we have a youth advisory group that sat and worked alongside the planning committee for this conference. Their contribution was invaluable, and you will hear directly from them during Thursday's plenary, so make sure you're there. It's going to be very exciting. Additionally, in the past few months, our nation has been confronted with the images of racial injustice in our society. This problem is not new, but the recent events have brought us as a nation to a tipping point where we as a country are saying no more. In support of this effort, AMCHP released an anti-racism statement acknowledging racism as a public health crisis, really one that directly impacts our communities and the health outcomes. And we also identify ways in which we have been a part of the problem. This was an important step as we embark upon reconciliation with communities we've negatively impacted or haven't prioritized appropriately. This was also a critical step in acknowledging where we've fallen short so that we can be laser focused on how to do better. In our statement, we outlined action steps for others interested in doing this work to take. We also invited you to be all in for what it will take to make this change. There is so much more work to be done. We will be having more conversation about this later today and throughout the conference. We are so excited to have this opportunity to share and discuss this and many more topics, with you this week. Although we can't be in the same location, we still value our time together and have tried to make this offering as interactive as we possibly can. Thank you for being with us, and we hope that you enjoy these next few days. We hope that you're challenged, refreshed, recharged, really to take these messages and learnings back to your community. Again, welcome AMCHP family. At this time, it is my distinct pleasure to introduce our next guest. We are honored to have with us Senator Tim Kaine. Senator Kaine has served as the junior U.S. Senator from Virginia since 2013, previously served as the 38th Lieutenant Governor of Virginia from 2002 to 2006, and the 70th Governor of Virginia from 2006 to 2010. Senator Kaine was also the 2016 Democratic nominee for Vice President of the United States. He is very passionate about maternal and child health and has been actively engaging stakeholders to better understand the issues around maternal mortality, morbidity, and disparities in outcomes. He was excited to be with us when our conference was scheduled to be in person in the state of Virginia, and we are so appreciative of his interest in still being with us, even though we've had to move to virtual. Thank you, Senator Kaine, for your time this morning.
Well, I want to thank you, Shirley, and thank everybody, nearly 1,000 maternal and child healthcare leaders for being together. You're right. I was originally going to be like doing a welcome to Virginia speech back in March. Whenever you've been a mayor or governor, you're always kind of into the welcoming and the economic development, and we would have loved to have had you, but obviously life has thrown all of us a big curveball. And let me start there. I'm just going to talk for a few minutes, mostly to thank you for helping me and my wonderful health policy expert, Katie Wright, introduce a bill dealing with maternal and infant success that I want to describe, but that AMCHP played a huge role in. But to begin, just to acknowledge the challenges that everybody's facing. You guys have really important work to do, and it's probably never been more important than now. And the work that you do on maternal and child health programs has its own set of stresses. But I just want to speak out to you and really, I guess, extend sympathy, solidarity, some sense of just personal connection as you all grapple with your own challenges during this time. Without knowing you all on this Zoom call, I know each of you probably have your own health worries. You have your own health worries about people in your family. Maybe health concerns have kept you from visiting a parent or grandparent in a nursing home, or maybe they've stopped you from being able to visit a child or even a newborn in your family to hold a child or a grandchild. You probably know people, and maybe yourself have economic challenges or anxieties that are heightened as a result of the economic devastation that coronavirus has brought to our country. As we see the replaying of the murder of George Floyd and other shocking instances that make our continuing racial disparities so plain, that has a traumatizing effect of increasing anxieties at a time when anxieties are already so high. And I just want to tell you, I'm just thinking about you as you deal not only with the increased anxieties in the work that you do, but in your personal lives. If you had told my wife Ann and I at the beginning of March that we each would have had coronavirus, that 2 of our 3 adult children would have been out of work for months, they both just recently gone back because their jobs were closed, that we would have known 4 people who have died of coronavirus, I would have said that's not possible. We're fortunate people with good jobs and good salaries and good health care and a good safety net. That's not possible, but that is in fact what's happened. And from the glancing effect of coronavirus on our family, it's made us really reflect how much more difficult it would be if we didn't have good jobs or didn't have good health care or didn't have a house where we could quarantine without stepping on each other's toes every 30 seconds. So I just wanted to start by saying that, you know, it is unfortunate that we're having to do this virtually rather than in person, but it's really unfortunate that so many people are living through such hard times. And while it affects everybody, I think we're seeing it who is getting sick, who's dying, who's losing their jobs. It certainly doesn't affect everybody equally. So I just wanted to speak that just person to person to all of you as you grapple with your own realities, which are tough in any event because of the important work you're doing, but are tougher now. When I was going to do my welcome to you in person in March, I was going to make some news, which was that my staff and I had worked with AMCHP and other organizations for a long time, and we were going to use that occasion to introduce a bill called the Maternal and Child Success Act, Maternal and Infant Success Act. About a year ago, I told one of my staffers, Katie Wright, who's my health staffer, you know, there's so much more that we need to do to help moms and newborns be successful. And wouldn't it be nice if we could do something in this space that the most ardent pro-life member of Congress and the most ardent pro-choice member of Congress could both say, yeah, of course, that's exactly what we should do. And so we embarked upon trying to put together a bill really focusing upon maternal and infant success with a special focus on maternal mortality and in real focus, the unacceptable disparities in maternal mortality in this country. Now, the theme of your conference this year is the power of connections, building equity for health generations. And this equity message is one that we have been focused on in dialogue with AMCHP, but also in dialogue with community leaders around Virginia and around the country. You know these statistics, but they bear repeating because even if you know them, they do shock you, and they should when you hear them. Among developed nations, the U.S. has disturbingly high rates of maternal and infant mortality, and the racial disparities are massive. Maternal mortality for non-Hispanic Black women in 2018 was more than 2.5 times higher than the maternal mortality rate of non-Hispanic white women. And when you look at infant mortality, it's pretty close. The infant mortality rate of babies born to non-Hispanic Black women is more than 2.3 times higher than those born to non-Hispanic white women. Any pregnant woman choosing to have a child should be able to do so safely without regard to income, race, zip code where they live. I mean, these things shouldn't matter. Everybody in society should be invested in wanting a child from the moment of birth to have the greatest opportunity of life success. And when there's disparities in infant mortality or disparities in maternal mortality that deprive a child of a mother at a young age in disparate ways, nobody in society can be happy with that. So that's why I, together with Senator Lisa Murkowski, who has a real long-time interest in this topic and a particular focus on American Indian women, tribal communities in Alaska, see very similar disparities. We introduced the Mothers and Newborn Success Act, together with the House companion bill that has been introduced by Congresswoman Terry Sewell. So Lisa Murkowski from Alaska, Tim Kaine from Richmond, Virginia, Terry Sewell from Alabama, together with other congressional colleagues. Kamala Harris has done a lot of good work in this area. Lauren Underwood from Illinois has done a lot of good work in this area. We want to make this a real focus. Bring down maternal and infant mortality, bring down the disparities, and now is the time to do it. We introduced the bill about 2 weeks ago, and one of the things that drove the delayed introduction, we were going to introduce it in March, we were working to get it right, but as some of you know, the CDC about a month ago changed the list of who they consider at high risk during COVID and added pregnant and lactating women. Pregnant women are women in the first months after delivery. Originally, the high risk list were those that were sort of maybe more familiar with the elderly, people with history of respiratory problems, diabetes, heart disease. But as we learn more and more about COVID, and it's tricky, and there's some things about it that are counterintuitive, what the CDC realizes it poses particular risk for pregnant and lactating women. And so having added that group of moms to the high risk list, we thought this would be a good time to introduce the bill because maybe we can get some pieces of it included in the COVID package that we're negotiating right now. What does the act do? A couple of things. It supports innovation in maternal health delivery and works to improve data collection on maternal mortality. We're seeing significant weaknesses in the public health data side of public health generally, not just about mortality. What is the race of people suffering and dying from COVID? We don't have complete data about that. We have to do a much better job at public health data, and that is one thing this bill will do in the maternal mortality space. It will strengthen support for women during the critical period that's postpartum, which is so important. It will help ensure that pregnant women get vaccinations that they need and also become aware of maternal health warning signs. And finally, the goal is to strengthen mental health research and to promote the use of telehealth, where we've advanced a lot. You know, some silver linings in the time of challenge. We've advanced a lot in telehealth. That's great. Can we use those advances to help high-risk expectant mothers, especially who might be in geographically isolated areas where access to care is more difficult? That's what the bill would do, and we are hoping to try to get some of it included in the COVID bill. And we introduced the bill with a sense of optimism, and I'm going to finish there and then just thank you for your work, and I know you've got many more speakers today. I have a sense of optimism about this bill, that we can get it passed because it's bipartisan, because everybody should want children to have the maximum chance of success when they begin their lives, and mothers too. No one can feel satisfied with these disparities. But I also have a sense of optimism because I think if we do this, we can actually be optimistic about reducing disparities. When I was the governor of Virginia from 2006 to 2010, I noticed something really weird about Virginia. There's many things that are weird about Virginia. There's other weird things about every state, but there was a weird thing about Virginia. We were like 11th or 12th in the nation in per capita income, but we were about 35th in infant mortality. And most measures like that, they tend to track, you know, states that are higher income tend to do better. Many governors before me had noticed the same thing and challenged Virginia's health officials. Hey, look, you know, there's just no reason for us to be a high income state and have a bad infant mortality stat. But nobody was able to really solve it because we didn't really have the right approaches. I hired a health commissioner in Virginia, and in Virginia, the health commissioner does health in the way we think about it, but also restaurant inspections and septic tank systems and everything else. But I hired a health commissioner and I just said, you just have one job, and that's bring down infant mortality. You can assign everything else to everybody else. That's your job. And she did a study of Virginia and what we had tried and came back and said, I can tell you why earlier efforts have been unsuccessful. Every governor notices just what you notice, and every governor says we're going to do something about it. And every governor comes up with a statewide program that takes some resources, but then spreads them so thin across the state that it doesn't give you much bang for the buck and actually get you a result. What my commissioner, Karen Remley, told me is you got 135 cities and counties. This is really an intense problem in about a dozen jurisdictions. If you are doing a statewide program and just spreading the resources everywhere, you're not going to get the bang for the buck. What you need is a super intense and targeted program at the communities that are most in need. And if you put all the resources into that, you're going to be able to make a difference. Well, Karen did that. She came up with the idea. She came up with the program. The legislature and I came up with the money. And when she followed that targeted approach, Virginia saw dramatic changes in infant mortality. We're more like national average now. We should be better, but we're not bottom quartile like we had been for so very, very long. And we're not satisfied with where we are. But what we learned from that is you do the program right, and then you can actually move the needle and make people's lives better. And so we approach maternal mortality issues in exactly the same way. If we do it in a targeted way, recognizing that the disparities actually point out to us the kinds of programs we should do, because it points out the kinds of folks who most need services, and most need services that are sort of attuned to them in language and culture and the way they live and the kinds of professionals that interact with them. If we do that, we should do it with a sense of optimism that we can make a difference. I know I have that sense of optimism, and I know you do too. So I'm going to conclude right there and just say you've got a really interesting conference ahead of you. Virtual isn't as good as in person. I look forward to welcoming you to Virginia in person sometime when we safely can. But thanks so much for what you do. Your work is important every day. It's never been more important than it is right now. And I hope you have a great rest of your conference. Appreciate the chance to share with you for a minute.
Thank you, Senator Kaine. We know how important maternal and child health issues are to you, but we also know how busy your schedule is as well. We appreciate you taking the time to be with us this afternoon. Thank you. At this time, I'd like to invite Dr. Michael Warren, Associate Administrator of the Maternal and Child Health Bureau, to offer a brief welcome.
Thank you, Shirley. Good afternoon, everyone. And as much as we'd like to be together in person, we really appreciate the opportunity to be able to join you virtually. And I think joining virtually is how we take care of each other and keep each other safe so that we in turn can take care of the MCH population. And I know we'll be back together in person again, and I very much look forward to when that happens. Wanted to walk through with you today just a few remarks. As you all know, at the Maternal and Child Health Bureau, our mission is to improve the health and well-being of America's mothers, children, and families. And we do that using our framework of Accelerate Upstream Together. You've heard me mention that before, and I think it aligns so nicely with your conference theme, the power of connections, building equity for healthy generations. When we think about Accelerate, we know that across MCH populations, there's so much need. 22,000 babies die every year before reaching their first birthday. About 700 women die every year from pregnancy-related causes. And less than half of children with special health care needs have a medical home. But beyond those high-level outcomes, there are also marked disparities, just as you heard Senator Kaine mention. If we think about infant mortality, Black infants are 3 times more likely to die than white infants. And if we think about maternal-related outcomes, pregnancy-related deaths, Black women and American Indian and Alaska Native women are 2 to 3 times more likely to die than white women. Those are not new disparities. And so as we think about doing this MCH work, we have to accelerate the pace of change. It's not acceptable for us to keep the status quo. We have to accelerate the pace of change of improvement. And we do that by looking upstream. Healthcare is absolutely important, but healthcare alone is not going to solve our problems. You all know well that many determinants of health influence overall health and well-being. Those include community factors, health behaviors, environmental factors, policies, as well as the experience of racism and bias. And so as we do this work, we necessarily have to address those root causes of inequity, of poor health outcomes across MCH populations. The upstream part of this also resonates with our MCH Focus on Life course. If we think about addressing the perennial challenge of infant mortality in this country, we can't do that without thinking about the health and well-being of women long before they become pregnant. And if we can improve their health, not only are we going to improve infant outcomes and reduce infant mortality, but we're also going to reduce maternal mortality and morbidity. Finally, the together piece of this is pretty self-explanatory, but it means we don't do this alone. The Bureau doesn't do it alone. AMCHP doesn't do it alone. And I know I'm talking to a bunch of rock stars out there in MCH land, but you all don't do this alone. We all have to work together to do this work. At MCHB, we take great pride in working with partners across the federal government. In just a minute, you're going to hear from one of my favorite public health colleagues, Dr. Wanda Barfield at the CDC. She and her team are doing amazing work around maternal health and infant health and a number of other MCH-related issues. We also work with other colleagues within HHS and across the whole of federal government, but also with state partners through the Block Grant and through McV, with community partners through programs like Healthy Start, with academic institutions and non-governmental organizations, and importantly, directly with families and consumers. As you begin your conference, your theme so deeply resonates with me. We have to accelerate our work to achieve health equity. And to achieve that for generations, we have to take a life course approach. We have to think upstream and across that life course as we do this work. And we have to do that together. So I want to thank you for allowing us to partner with you as you do this important work. We continue to be available to you to support you as you do this incredibly important work during trying times, as you work to address the impact of the COVID-19 pandemic on MCH populations. We so appreciate the invitation from AMCHP to join you over the past few months in the biweekly town halls. We also appreciate the opportunity to have office hours with you during this conference. So we had a great session with state and jurisdictional colleagues earlier today. We'll be repeating that again at 4 p.m. this afternoon and again at 12:30 tomorrow. Those are informal opportunities for you to join me, members of the staff here in the Maternal and Child Health Bureau, including our deputy, Laura Kavanaugh, and share your thoughts and concerns and let us think about how we can support you as you do this work. Again, thank you for the invitation to be here. So excited about your conference, and we look forward to partnering with you virtually and learning more about this exciting theme. Thank you.
You know, it wouldn't be a virtual conference if there wasn't a minor forgetting to unmute yourself. Thank you so much, Dr. Warren, for that welcome and your partnership on behalf of AMCHP and your leadership. We really do appreciate you and the Bureau. At this time, I would like to invite Dr. Wanda Barfield, Director of the Division of Reproductive Health with the CDC, to offer a brief welcome.
Thank you. I just want to say hello to everyone. It's so great to see you all virtually. I'm Dr. Wanda Barfield, and I direct the Division of Reproductive Health at the Centers for Disease Control and Prevention. And I just want to thank Dr. Kaine, Senator Kaine, and Dr. Warren for their remarks. And I also really want to thank Jonathan Webb for his leadership and the leadership of many of you here and the collaboration that's represented. I want to thank you all for your contributions, outcome, and improving the outcomes of women and infants, children, and families in the United States. And while we know that COVID-19 has drastically changed our world in the way that we work and gather, I'm really happy that we can meet and have so many esteemed colleagues here with us virtually. I want to particularly thank AMCHP for their hosting of this meeting. And it may not be the meeting that they had planned back in March, but it demonstrates their patience, their perseverance, and their absolute commitment to this important work. Now, today, more than ever, we are aware of the disparities that exist for Black, Indigenous, Latino, and other women of color who are often experiencing far worse health outcomes than their white peers. And the disparities in health exist across the lifespan and are sustained across generations. And there are significant disparities that we know in preterm birth, infant mortality, teen birth rates, maternal mortality, as well as chronic conditions. And looking specifically at maternal mortality, we know that data from the Pregnancy Mortality Surveillance System, or PMSS, shows us that the overall maternal mortality in the US has not improved over the past decade. And there are considerable racial disparities. American Indian, Alaska Native, and Black women are 2 to 3 times more likely, respectively, to die of pregnancy-related causes than white women. And PMSS data show that inequities increase by age and are present in all education levels. And the increasing disparity by age supports the weathering hypothesis, which proposes that Black and American Indian, Alaska Native women experience earlier deterioration of health because of the cumulative impact of exposure of psychosocial, emotional, economic, and environmental stressors. But we are making progress. And we've been working to strengthen the data on maternal mortality by identifying the processes to improve vital statistics and also getting more in-depth data to better understand the story of a woman's life and the circumstances of her death so that we can improve prevention efforts. This includes documenting clinical and non-clinical data, such as information about social determinants of health and information on discrimination and bias. CDC also supports 13 state perinatal quality collaboratives, or PQCs, and the national network of PQCs. And these state-based initiatives are helping to translate the information coming from MMRCs into quality standardization and improving care for women and infants. And I must say, it's great to see the collaboration with the PQCs and the AIM bundle. In addition, CDC Locate also helps states and other jurisdictions monitor systems of risk-appropriate care in their region, enabling them to ensure that women and infants are treated at a facility that can provide them with the care that they need. And I'm also excited to share tomorrow on August 5th that we will go live with the Hear Her campaign. Now, this campaign is going to increase awareness of maternal morbidity and mortality through warning signs, providing women with the information that empowers them to raise their concerns and encourage women's support systems and really listen and help women get the care that they need. Remember, cdc.gov/hearher. However, COVID has further invigorated our commitment to improving the health and well-being of all mothers and children, particularly as they face yet another health challenge that's disproportionately affecting women of color. And while limited information is available about COVID-19, infection in pregnant women from a recent report found that pregnant women may be at increased risk for severe illness with COVID-19. And Hispanic and non-Hispanic Black pregnant women appear to be disproportionately affected by COVID-19 infection during pregnancy. Long-standing systemic health and social inequities have put many racial and ethnic minority groups at increased risk of getting sick and dying of COVID-19. So we all have a role to play. We need to do more to protect the health and well-being of women and children of color in the US. This is a daunting challenge that we will continue to take coordinating efforts across sectors in our professional as well as our personal lives. And I'm looking forward to hearing from our speakers today and our continued collaboration to advance equity and improve outcomes for mothers and children. Thank you.
Thank you so much as well, Dr. Barfield, for your welcome, your partnership, and your leadership as well. And now I'd like to turn it over to Jonathan Webb, CEO of AMCHP.
Thank you, Dr. Payne. Thank you, Dr. Barfield, Dr. Warren, and all the previous constituents who've offered their welcome. Welcome, everyone. I'm so excited to be with you today. And thank you so much for carving time out of your busy schedules to be here with us. This is definitely a different environment than we were anticipating when we started planning for this conference a year ago. But like most of us these days, we've had to learn to adapt and be flexible. So in that spirit, we ask you for grace. This is a first pass at a virtual conference, but there's been a lot of time and energy and effort to go into this when we put together something that we think you'll really enjoy. I wanted to first take a moment to acknowledge and thank all the people that have helped to get us here today. Thank you to all of our speakers and presenters who persevered. You'll hear that word several times, perseverance, and were willing to adjust to a virtual platform. Thank you to our exhibitors and sponsors for sticking with us and adjusting to this new format. I would invite all of our attendees to please support them, show them the support they've showed us by spending time with them and visiting their virtual booths over these next few days. And I'd also like to mention a sponsor who was not a part of the formal sponsorship process, but decided to, in some of our conversations, to offer a free resource to all of our conference attendees. I don't know how many of you have read the book Switch by Chip and Dan Heath. They've made books like Made to Stick, Moments, things of that nature. Dan Heath has a new book out called Upstream that aligns very nicely with Dr. Warren's comments earlier and Dr. Warren's challenges around Accelerate Upstream together. So Dan has made it possible for everyone who's registered for this conference to receive a free copy of his book. So you should receive that by the end of this month to the address that you registered with. So I wanted to thank him as well. I'd also like to thank our AMCHP staff members who have really been behind the scenes making this all possible. Every AMCHP team member played an integral role in getting us here today. So if you have an email address or a way to contact one of our AMCHP team members, I'm sure they would appreciate a shout out or a kudo just acknowledging the work that they have contributed to this event. And as I share with them all the time, I consider it an honor and a privilege to work alongside such bright, talented, and passionate professionals. Last, I'd like to thank you all again. If we were in person, I'd ask you to give each other high fives, but that is not compliant with our socially distant rules these days, so that wouldn't happen. So I'll just offer you virtual kudos. Thank you for everything you do on a daily basis. Thank you for your sacrifice and dedication under normal circumstances, but especially during these unprecedented times. Your leadership and involvement have helped tremendously in our response to COVID. And like Dr. Payne said earlier, if it was not for your involvement and your leadership, I can't imagine where we would be in this moment. So I hope that that you feel that we have created an environment that still gives that family feel that we've all come to appreciate with AMCHP. And in that same vein, I'd like to offer in a safe space among my family members a few thoughts. This has been an interesting year. And while I, like most people, am looking forward to getting this behind us, I don't want to miss the opportunity among the chaos. One of my favorite quotes from Frederick Douglass is, "If there's no struggle, there's no progress." This resonates with me now more than ever. And there are a number of points wrapped in that I'd like to share. I'll only briefly share two. One of those points is that power concedes nothing without a demand. In our culture right now, whether by default or design, the moment in which we live requires that we evaluate and challenge the systems of inequity around us and demand a change. I think we're seeing that on full display. Two, implicit in his comments is the understanding that without uncomfortability, pain, or struggle, there can be no advancement. Until we become uncomfortable enough with our situation, there is less motivation to change it. All around us, we see examples of that. COVID and the inequities it's highlighting, disproportionate maternal mortality and morbidity rates among Black and Brown women as compared to their white counterparts, systems that aren't functioning well for families who live with special healthcare needs, and the list goes on and on. We are in a moment right now where the uncomfortability around these issues is rising to a level where people are demanding change. The challenge that I want to extend to you as leaders in MCH is to seize that moment. And I'd like to invite you to do three things. In keeping with the conference theme, one, we must understand the importance and power of connections. The goal to improve the health of women, children, families, and communities should be the responsibility of every industry, sector, generation, and community, because we're all connected. 2, we must be focused on change. The status quo must be challenged, and we have to continue to embrace our roles as change agents. We all get it. It is now incumbent upon us to invite others along for the journey, in whatever sphere of influence we may exist or have access to. 3, we must remain committed. We are running a marathon, and while we are focused on the end goal, we must endure to the end. I'm excited to be on this journey with you and look forward to see what we'll accomplish together. I am pleased to have this conversation continue in this plenary by one of my friends and colleagues, Dr. Zaya Malawa, who is the Director of Expecting Justice in San Francisco, which looks to address racial disparities in birth outcomes. She also has researched best practices for teaching anti-racism to healthcare providers and public health practitioners. Today, she is going to help us take a look at how we chase zero in maternal and infant deaths through advancing equity by investigating historical trauma. I'll turn it over to you, Zaya. Thank you.
Thank you guys so much for having me. I feel like this has been a really long time in the coming, and I'm so glad that I finally get to do this virtually, as the case may be. In anticipation of this conference, I've been trying to recreate a conference experience for myself. So I got a really poor night of sleep last night, just like as if I were in a hotel. And when I woke up this morning, before I even got in the shower, I went and I draped my jacket over my office chair so that nobody would take my seat. I'll be sipping on some coffee flavored tea, just like you get out of the urns at a conference, just so that I can really have an authentic experience. So I invite you guys to do the same. I was invited here today to talk to you guys about the relationship between racism and birth disparities. And I'm feeling really grateful, honestly, that I get to talk about this, especially in this moment, because I think it's really important that we really have an authentic conversation about how racism is producing these disparities. And just want to mention briefly that, you know, I'm from San Francisco, so assume all the things that go along with that. B, I consider myself an activist physician, or more specifically, a Blacktivist physician. And what that means to me is that I see my role as a physician to not just take care of my patients, but also really like, what does it look like to heal the systems in which my patients have to exist. So I want to invite all of the clinicians out there to add an activist moniker to your name and join me in this work. Lastly, I just want to mention before I start that for the purposes of this conversation, I'm going to be focusing on anti-Black racism and Black mothers and Black birthing people. And that is not by any means to imply for a single second that Black women are the only people who are experiencing birth disparities, but it is just a reminder that birth disparities are falling hardest on our community, so we're going to center there today. So, you know, I want to start by just kind of having everybody question for themselves, what do you understand to be the root causes of birth disparities? Because I think a lot of us recognize that birth disparities are real and are disproportionately impacting Black women, Indigenous women, and other people of color. But a lot of times we don't get deep into the roots of these birth disparities. And as a result of that, a lot of times we might make some problematic assumptions that it's related to differences in behavior or biology. And so I just want to remind everybody that, in fact, we know from research that that is not the case. There is nothing inherent about being Black that makes you at higher risk for adverse birth outcomes. In fact, the only thing about being Black that makes giving birth so risky is the racism that we experience. And so I want to invite us to kind of make sure that we are using this frame throughout as we talk about birth disparities. And if we're going to understand this issue deeply, we kind of have to start at the beginning. And, you know, of course, in the United States, the beginning of Black birth disparities is slavery. There was a study that was done in 2015 that estimates that the amount of wealth that was stolen from American Black communities in the form of slavery would amount to around $17.5 trillion in today's dollars. So when we are seeing Black poverty in this country, it's really important to understand it in this context that already, right from the jump, when other communities were able to immigrate to this country to build wealth, Black Americans came to this country and had wealth extracted, and often in the most brutal ways possible. I also want to name that Indigenous people are also owed around $17 trillion for the incredibly brutal extraction of wealth from their communities as well. And, you know, a lot of times when I'm talking about slavery, people will say to me, well, you know, my family wasn't here when that was happening, so, you know, that's not really something that I'm concerned with. And I just want to remind everybody at the conference that if we live in this country right now, we are all enjoying the benefits of living in a wealthy, developed nation. One of the critical reasons why this country is a wealthy, developed nation is because of the global economic advantage this country had by the century and a half of free labor and all of the stolen land. And so if we are benefiting from this global economic advantage, then we also just have to own that there's a debt that comes along with this that remains unpaid. Please. Oh, absolutely. I am. It would absolutely be my pleasure to share my screen, and I am so sorry. Hold on. Can you see it now? Can you see? Perfect. Thank you. I'm so sorry about that. So anyways, what I wanted to also mention is that one of the other costs of slavery is this legacy of racist policing that is coming to a head in this country. A lot of people don't realize this, but this nation didn't have a standing police force for much of its early history. But what we did have is a standing slave patrol throughout the eastern part of this country. And in the South, the slave patrol basically operated to police slaves. And in the North, the slave patrol functioned basically to catch runaway slaves. After the Emancipation Proclamation, there was technically no need for a slave patrol anymore. But what you found is that the policing of Black people continued, and it continued relatively in the same fashion that it existed when the policing was done by the slave patrol. And one of the things I would point out is that the policing changed so little that even the badges are relatively similar, because what you can see on the left are slave patrol badges from the 1800s, and what you can see in the middle column are actually police badges and sheriff badges from today. The top one is from my city, San Francisco Police Department, and the bottom one is from Genesee County in Michigan. So when we are seeing this racist policing, we have to understand that it has centuries-old roots, and also that the costs of slavery continue to impact Black Americans today. I want to mention that another cost is this extreme dehumanization of Black women, and not that Black women were the only ones who were dehumanized by the process of slavery, but germane to this conversation around birthing justice, we have to talk about the ways in which Black women experienced extreme amounts of medical abuse, physical abuse, and sexual abuse throughout slavery. And there has been no attempt to restore or heal these traumas that were so prevalent during slavery and afterwards. And so intergenerational trauma is real, and Black women continue to live with the consequences of this extensive trauma within our genetic expression in the form of epigenetics. But I would also say that our country as a whole continues to live with that trauma. One manifestation of that is this study that was done in 2016 with medical learners. And when I say medical learners, I mean medical students of all years and medical residents of all years. And basically, the study asked medical learners what they believed about white people versus Black people and their biological differences. And for people who don't have a medical background in this conference, I need you to understand that there are no actual definable biological differences between races, because race is a social construct. And so it's pretty remarkable that these students who have been learning medicine for some significant amount of time continue to hold these racist and problematic beliefs. You know, for instance, you know, these students, 39% of them believed that Black people's blood coagulates more quickly than white people. That misbelief has serious ramifications for the health and safety of birthing Black people and other mothers. I would also point out that these students, 20% of them believed that Black people's nerve endings were less sensitive. 58% of them believe that Black skin is thicker. And so when we hear these stories about Black mothers not getting adequate pain treatment or medical care, you know, probably these racist beliefs are feeding into that. And these racist beliefs have their roots in slavery and the mentalities that went along with it. Of course, I'm sure that most of you guys know slavery in this country ended in the mid-1800s. But that is not when the abuse of the Black population in the United States ended. It continues, as you can imagine, to this day. One of the forms in which this abuse took form was through terrorism. Terrorism happened on community levels through things that were often described as race riots. I didn't have as much time as I would love to unpack American history with y'all, but I would encourage people to look up the history of race riots in Tulsa. I would encourage people to look up Rosewood. I would encourage people to please look up the Red Summer and understand these aspects of American history, because basically what was happening was that there was large-scale Black wealth destruction that was masquerading as a race riot, and it happened over and over again. But this terrorism was also happening on an individual level because wealthy white landowners had become very accustomed to cheap Black labor. And when slaves were emancipated, they were not prepared to pivot appropriately to find new sources of labor to maintain the economic system they had developed. And so instead of pivoting, they began terrorizing Black people in this country as a way to maintain a cheap labor pool. A lot of times when we hear in this country stories about lynching, we understand it to be the result of a Black person committing a crime or the perception of a Black person committing a crime. But Ida B. Wells, and a very important journalist from that time, she started to write about and notice that actually a number of Black people who were lynched were actually people who were having economic success and therefore creating a threat to the systems that were existing in this country around Black labor exploitation. The kinds of things that Black people could get lynched for throughout this history in our country were relatively small. You could get killed for gambling, quarreling, arguing with a white man, acting suspiciously. I would argue that Black people continued to get lynched for very similar things. What you can see on the bottom of this slide actually is a group of white people from the mid-1900s. And they look like they're having a great time. Men, women, smiling. I don't know if you can notice in the background, but this is actually a lynching party. And I show this picture because I think that a lot of times in this country, we have this perception that lynching was this thing that happened in secret, with people's faces covered, you know, only maybe men of the community, and that there was a lot of shame around this. But that, in fact, was not the case. You know, in general, lynchings were like picnic events on Sundays after church. They were full family events, and it was not a solemn occasion, but often an occasion for celebration. And I think it's important for us as a country to reckon with this not so long ago history, because, you know, I personally cannot imagine what it would take to bring my kids and my family to a picnic where a mutilated, burned, dead body was hanging not feet from me. I can't really imagine like the mentality around that. I don't think that most of us could imagine like how that works. And yet Black people in this country were so thoroughly dehumanized that that was a regular event in this country, and not just in the South. Please look up the history. It happened all over the country. So none of us are immune from this. And so it's really important to understand the level of dehumanization that we as a country do with us Black people, because I need us to understand how far we have to come. When we see police officers in Aurora laying out entire families in a parking lot, handcuffing them while 6-year-olds have to lay on their stomachs with guns pointed at them because they're Black, when we see that, I really question how far have we come as a nation in restoring the full humanity of the Black community. And I need us all to authentically reflect on that if we want to see change. But it wasn't just the direct forms of violence that was impacting Black people in our history. There was also a phenomenon that we call structural violence that is also impacting us. Structural violence is basically when laws and policies, institutional practices are threatening the actual health, the physical health and well-being of marginalized groups. And so, for instance, an example of structural violence is redlining. I don't have time to tell the whole story of redlining in this country, but it's really important that we understand this history. So briefly, I want to mention that as part of the New Deal programs, one of the things that was developed was the Federal Housing Administration, the FHA. And one of the advents of this new government agency was that they would insure home loans for new homeowners. And what this did is it allowed banks to not have to take on so much risk when people wanted to take out loans to buy a home, because prior to the FHA, there were very few homeowners in the United States. And that was because you needed to put, at least 80% down for a down payment. And then you could only take out a loan for like 5 to maybe up to 15 years. So you had to have a lot of wealth in order to buy a home in this country. After the FHA, because they would insure these home loans, people could do what we're more familiar with, which is to buy a home with 20% down and to be able to pay that loan off over 30 years. But here's the thing is that the FHA would only insure loans in white areas. And it was so deep that they would actually code maps of cities with different colors to kind of let you know how safe an investment would be in that area. And you can see that they actually use terminology like BEST, which was color-coded green, which was a really safe area to insure loans, versus quote-unquote hazardous, which was colored red, and that was basically defined by the presence of Black homeowners. So that's why we call it redlining, because when there was a certain concentration of Black homeowners in an area, that entire area would become redlined, and then nobody would want to make investments in there or make home loans in that area. This strongly encouraged segregation, because you can imagine that homeowners would not want any kind of concentration of Black people in their community, because then they would also be experiencing that disinvestment of redlining. But also, Black families were unable to get loans, and so they were forced into very challenging and problematic predatory loan situations that just sucked so much wealth out of hardworking Black families. Black soldiers returning from World War II were unable to take advantage of the GI Bill benefits, again, because they couldn't get these home loans. And housing prices soared after World War II, and many Black people were excluded from this opportunity for wealth accumulation that served many white families very well because of this practice of redlining. And we as a community are still reeling from this lack of wealth. I want to describe another form of structural violence, and that is urban renewal. And I want to describe it as a lesson, because basically urban renewal is a masterclass on how you decimate Black livelihood in just a single generation. With urban renewal, step one is that you have to make investments in Black communities nearly impossible. So as I already mentioned, with the process of redlining, you can imagine that as a business, if you were trying to figure out where you were going to open a store, open a factory, you were going to look at these maps, and if you saw something that was literally demarcated by a government agency as hazardous, you probably weren't going to set up shop there. Likewise, for Black homeowners, it was really difficult to get home improvement loans or other kinds of capital to be able to build and grow their communities. So the first step was to make it nearly impossible for Black communities to get investments, basically assuring that these communities would stay poor. Step two, you got to promote a narrative that poor people are a threat to cities. President Eisenhower was a very racist president, if you didn't know, and he was a huge proponent of urban renewal. And he had this narrative that said that one of our biggest problems in this country is this quote unquote urban blight. And this idea of urban blight was really coded speech for people of color poverty for the most part. Step three, what you do is you create a financial incentive for government to displace Black families. And so basically the federal government made millions of dollars available to states and city governments to be able to clear and rebuild quote unquote blighted areas. And as you know, to meet this definition of blighted, there had to be a certain level of poverty. But also I will say that when we look in retrospect at what communities actually experienced urban renewal, they were overwhelmingly communities of color, and especially impacted were Black communities. Step 4, you use eminent domain to displace marginalized people so that the government can kind of do a major land grab at bargain prices. And then lastly, to complete the cycle, you demolish all of the homes in the area that you have acquired through eminent domain, and then you sell the land at a profit to private developers. You can see these pictures are basically what urban renewal looks like in my city, San Francisco. San Francisco used to be known, believe it or not, as the Harlem of the West. I will say as a Black San Franciscan, I cannot even imagine what it would be like to have a thriving Black community here. We're now known to be the city in the country with the highest impact of gentrification. But you can see here in the upper left, that was Harlem of the West, San Francisco. In the middle, you can see the destruction of all of these beautiful Victorian homes. They displaced more than 8,000 families, most of whom were Black. And then you can see in the bottom right corner that all we got in return were these hideous modern buildings that are owned by corporations. I would encourage everybody at this conference to look up your own city's history of urban renewal, because there are very few cities that were able to escape that history. So how are we doing now? I wish I could tell you guys this wonderful story of victory, but I'm sure it's not surprising to anybody at this conference that Black people continue to experience incredible levels of marginalization. For one thing, I would point out, and I think this is surprising to many people, that Black and white communities tend to use drugs at more or less the same rate. You can see that that kind of mint color represents white substance use, and that gray color represents Black substance use. You can see that maybe Black people smoke a little more weed and maybe white people take a little more LSD, but more or less across all drugs, it's pretty similar. But when you look on the right here, you can see that the rates of incarceration for substance use are so disparate, not even close of a comparison. And we can't explain this disparate incarceration of folks strictly by who's using more drugs. So often as Black people, we're told, well, you know, if people could just go to school and get an education, everything will be fine. But I want to point out that Black and white people at this point are more or less going to college straight out of high school at the same rates at this point. Unfortunately, we do not have the same returns on that investment of school. You can see that a Black college graduate is likely to earn less than a white person without a college degree, and the same is true for Latinx people. And I also want to point out how very, very difficult it can be to even get an opportunity to get a job in this country as a Black person. On the left, basically, what this study showed us from 2004 is that when they sent out a bunch of resumes with names that we traditionally associate with white individuals, they sent out low quality ones and high quality ones. And you could see that there was a difference in terms of who got a call back if you were white. When they sent out resumes with Black sounding names, it didn't even matter if you had a low quality or a high quality resume. You were going to get called back around the same rates, and those rates are significantly less than the rate at which white people get called back for job interviews. On the right here, you can see that a white person with a criminal record has a greater chance of getting a job callback than a Black person that has no criminal record. When we are disproportionately incarcerating and criminalizing Black people, then you can see that a Black person with a criminal record really has no chance of participating legally in our economic system. It is really difficult. The cumulative toll of all of this are these insane racial wealth disparities that we have in this country, wherein the median assets of a white family is over $100,000 and the median assets of a Black family is around $2,000, and that equals no safety net. And so that means that most Black families are one major illness, one catastrophic accident, one job loss away from economic ruin. And so probably most of you guys know that the Institute of Medicine puts out reports about, you know, preterm birth, the causes, consequences, and preventions. And I did you guys a favor. I read that whole report. And what I learned is that the risk factors for preterm birth are acute stress, racism, neighborhood conditions, anxiety, socioeconomic status, and chronic stress and work conditions, right? And what I just hopefully explained to everybody is that Black people are disproportionately impacted in all of these areas. And when I'm talking about, you know, this idea of structural violence, I'm not talking about like an abstract concept. COVID is showing us that literally policies and laws are stealing the lives of racially marginalized people. And so if we want to see changes wherein Black women and other people who are experiencing marginalization can have healthy births, then we have to change structures, laws, policies, and practice, which is a big lift, but it is really satisfying work, let me tell you. I want to help you guys know when I'm saying changing this kind of stuff, what does that mean? When I'm saying that we need to address racism, how do we do that? So the way that we've been doing it at Expecting Justice in San Francisco is that we've developed this concept called the racism as a root cause approach, or the RRC. We want it to be a thing like an RCT, so we've given it a little name called RRC. And basically this idea is that if we know that racism is at the root of any health disparity, including birth disparities, then we have to address racism if we want to close the disparity. So what does that look like? Well, so the first thing is that any intervention that is meant to address racial disparities, if it's going to be an RRC, it has to be long-term. Because the thing is that these racial disparities were centuries in the making, right? Like racism in this country has been brewing for centuries. So it is ridiculous to think for a single second that we are going to be able to undo these challenges within a few short years. 5-year programs, 8-year programs, like what is that doing in the face of 400 years of discrimination and oppression? And so when we're addressing racism as a root cause, we have to plan for long-term, and I mean multi-decade interventions. I know that that is not always easy because the money is not always set up that way. And so if it's not like readily available to set it up that way, then at the very least, if we're going to do a pilot, we have to simultaneously be planning for what the long-term vision of that pilot would look like. It's no longer helpful to just do a pilot and then disappear. And I would say that in my work, at least, we've had the most success in terms of creating these long-term or institutionalized interventions by changing laws and institutional practices. And so that's what you're ultimately going for when you're trying to do an RRC, is how do we change laws at the state, local, or federal level so that there is a permanent funding stream, or so that this program is permanently embedded in the agenda of the local agencies that control the government. Another component of racism as a root cause intervention is that it has to have a precise impact. And by that, I mean it has to really focus specifically on the group that is experiencing the racial marginalization. A lot of times, as Senator Kaine kind of alluded to, we like to have these kind of universal approaches where we're going to just kind of do a one-size-fits-all. But the challenge is that people who are having babies are not all starting from the same place. And so when we do a general approach, we can't be surprised that it yields unequal outcomes. And so what I'm advocating for is that we really look at the groups that are experiencing marginalization, and we even engage those groups directly, and we pay them to offer their expertise to help us understand what are the specific barriers that you are facing. How specifically does racism manifest in your community? And then we have the courage to be willing to focus in on those groups. I'll say that, you know, in San Francisco, we have done a lot to ensure that everybody has the opportunity to have insurance. And we have universal programs within my city that are really great to make sure that anybody who wants to have health insurance can have it, regardless even of their immigration status. But here's the thing. The lack of insurance is not what is driving all of these health disparities. And so by not addressing the other barriers that are impacting, for instance, Black people who are having babies, by not addressing their other barriers, we haven't actually closed the margin at all. We need to have a precise impact. When we talk to these communities, they tell us how it is really unpleasant to go to the doctor because doctors often are very racist with them. They tell us how transportation is very difficult, and closing the insurance gap doesn't address any of those. So we have to be willing to have a precise impact and understand what are the precise barriers that are facing our communities. Racism as a root cause interventions focus on systems change. So often people want to equip Black women with resilience tools, information, education, so that we as Black women can be more resilient in the face of ongoing oppression. But that's not addressing racism as a root cause. In some ways, that's actually advancing it, because for Black women who are already experiencing so much stress, to then have to take on the burden of overcoming a racist system can be very exhausting. And so when we're doing a racism as a root cause intervention, we're advocating that people change the systems and environments instead of trying to change the people. We focus on policies, systems, institutional practices when we're doing a racism as a root cause intervention. And lastly, I would say that racism as a root cause interventions have to focus on reparation. We as a Black community cannot squeeze water from a stone. So much wealth and frankly wellness has been extracted from us. We cannot reproduce that magically from thin air. We have to be reinvested in if we want to see a restoration of birth justice in this country. And so racism as a root cause interventions demand that we do reparations. Now, I know that cash reparations may not always be an option. And so what I'm advocating for is that when we do reparations, we have a really clear focus on shifting resources, power, and opportunity from groups of racial privilege to groups that have and are experiencing racial marginalization. So I'm going to tell you what often happens in my city in San Francisco is that our government or one of our large institutions might get a grant to do some work around racial health disparities. And what usually happens is right off the top, the indirect fees are going to absorb a huge percentage of that money, so that a huge percentage of those resources that were granted are already going to stay within the white-led power structure, and community will never have access to that. And then what usually happens is that because of time pressure and complications and these different things, these institutions will kind of decide what program they're going to do, and they will not involve in any kind of meaningful way the directly impacted communities in the decision-making around what's going to happen with the money. And so in doing that, they continue to hoard also the power that's associated with this new initiative. And then a lot of times for, reasons of civil service or other reasons, educational needs, et cetera, in my city at least, we will often hire people who are not of the community that's most impacted. And in doing that, now we're also giving all of the opportunities, not to the community, but rather to the people who already experience a lot of privilege. And so what usually happens is that we hoard the resources, powers, and opportunity, and all community gets is a program that they may not have even asked for. And so what I am advocating for in RRCs is that we keep a really clear eye on the flow of resources, power, and opportunity. And whenever we have the opportunity, we shift those things from the institution into the hands of the communities that are experiencing marginalization. So when you take all of these things all together, then you're doing an RRC. And when you can incorporate these elements into your initiative, now you are addressing racism as a root cause, getting at these root cause issues so that a generation from now, we're not looking at the same birth disparities. What does this look like in practice? Because I will say that, this isn't simple or easy. Like, I don't want to pretend for a second that I'm asking people to do this light lift. One thing that I will offer is that, if you can't get all 4 components, can you get 3? Can you get 2? Like, some is better than none. I would also offer that if you already have existing programs, how do you start to incorporate or weave in some of the RRC components into what's already going on? I want to give some more practical examples just so that this makes sense. Again, kind of really focus on my city and state because I know it best. The California Department of Public Health in 2017 did an educational initiative around Black birthing disparities. And one of the things that they did is they really pushed out this flyer up and down the state around what Black women need to know. And it basically, tells Black women how they can reduce their risk of preterm birth. And it focuses on individual health behaviors. And something else that's hard for me is that it names that Black women have birth disparities, but it doesn't say why. And so there is an implication when we're focusing on health behaviors and saying Black women, you have a higher risk, that it's Black women's behavior that's causing these health disparities. So one thing that I would also offer to the conference is if you're going to name that Black women are having disparities, please also be specific about why. Okay, so we have this educational flyer to help Black women. What is the flyer teaching Black women? It's telling them that they should take a daily vitamin. They need to go to the doctor. Please don't smoke, Black women. Eat healthy and exercise. And then lastly, of course, you know, make sure everyone's helping you, because having a baby is tough. This is very valuable advice. So my question is, oh, sorry, this was put out in 2017 in California, and then this is our birth data in San Francisco. So you can see that between 2017 and 2018, the intervention didn't have the desired effect, because not only did the Black preterm birth rate increase, but the disparity widened. And you can see in San Francisco, where I know we like to think that we're a very progressive city, that Black women are having preterm birth at twice the rate of almost everybody else in our city. Okay, so is it an RRC, the health education intervention? Well, is it long-term? Health education interventions are often short-term. They deliver information at just a single point in time. And as we've already established, like a single point in time intervention is not going to be adequate to 400 years of racialized oppression. Does it have a precise impact? Well, you guys saw that these tips are applicable to all populations. Like, tell me the pregnant woman that shouldn't get help from her community or take a multivitamin, right? So no, it didn't have a precise impact, because it is not specifically addressing the very precise issues and barriers that are impacting the California Black community. Does it focus on systems change? No. This one is really asking Black women to do all of the work rather than addressing the system that is putting Black women at undue risk. And then lastly, reparations, say it with me. No, it does not repair historical injustices, because it in no way is shifting resources, power, or opportunity to Black birthing people. So what's an alternative? So I want to tell you guys about what we're lifting up here in San Francisco. My group, Expecting Justice, is going to be launching something called the Abundant Birth Project as an RRC intervention starting in November, but we've been doing the prep work all along. The Abundant Birth Project is basically going to be a basic income, a cash supplement for Black and Pacific Islander pregnant people in San Francisco. We're going to be giving these mamas $1,000 a month for their entire pregnancy, and if our fundraising continues to go well, up until 6 months postpartum, so that they can have some financial security and a little less stress. And we're curious to see what's going to happen. In San Francisco, it's Black and Pacific Islander folks who tend to have the worst birth outcomes, and so that's who we are centering. We're hoping that this cash is going to alleviate stressors during pregnancy. It's going to alleviate financial worry. It's going to give pregnant people an opportunity to have more housing security and better nutrition access. And one of the most enjoyable things about this process so far has been the fundraising. No, I'm kidding. That's been horrible. What has been enjoyable about this has been us really working to keep community voices at the center of planning this program. To start, we trained 4 mamas, 3 Black mamas and 1 Pacific Islander mama from the community to be qualitative researchers. And we taught them first how to do qualitative interviews. Our community researchers were amazing, and they turned around and they interviewed 25 other Black and PI women in their community. And you should know that they pulled this off like right as COVID was hitting, and I was just so impressed. We gathered all of that data, and we taught our community researchers how to do qualitative analysis. And them, along with our academic partners and Expecting Justice, we have analyzed the data, coded the data, and then last Monday, we convened 15 Black and/or Pacific Islander mamas, and we had a design thinking sprint. And we turned it over to the mamas. What should this program look like? How should we deliver your money? How many people should we be trying to reach for how long? What should be the income cutoff for who is eligible? Like, we really want these mamas to design the project. And y'all, I can't tell you how gratifying it has been to bring these mamas to the center of the program. Like, they are thrilled and I am thrilled, and love it. We have also budgeted throughout enough money to pay these mamas for their expertise, because we recognize that what they're doing is providing expertise. And in the same way, how if we hired a perinatal specialist to help us understand the medical implications of starting a progesterone program, we would pay them for their expertise. We at Expecting Justice feel strongly that we need to pay community members for their expertise because we value it just as much. So it's been a pleasure to do this community engaged work. Is it an RRC? Well, let's talk about it. Is it going to be long-term? I'm hoping so. From the moment that we even had this idea, we immediately started to talk to policy folks about how we could use earned income tax credit policy to become the long-term pathway for sustainability for this pregnancy income supplement if our pilot program shows that it's successful. And this is an ongoing group that we have been working with to really explore this possibility and to be ready to pivot with the legislative action that we would need to do if our pilot results yield the results that we're expecting it to. Does it have a precise impact? It is, because this is designed by and offered to specifically Black and Pacific Islander mamas, who are the people that are experiencing the greatest burden of risk when they have babies. Systems change? We like to think so, because rather than asking these mamas to do the heavy lifting of overcoming a racist system, we're creating an environment in which they can access cash that they need in order to be healthy while they're pregnant, without a lot of restrictions, without a lot of humiliation of interacting with our welfare systems, and in a way that doesn't require them to do extra work. And does it provide reparations? Ding, ding, ding. We believe so. We believe that this shifts resources and financial decision-making power and financial power overall to the Black and Pacific Islander parents, and it does so unconditionally, because we are not asking anything from these mamas when they receive the cash. We think that enduring this racist system is already asking enough. So that is what we believe an RRC intervention looks like. And I just want to name, as a Black mother, to this entire group that, you know, we have daughters who are going to be having babies, and we really want them to live through that experience, but it's not guaranteed that they will. And we Black women, we can't change the system, unfortunately, on our own, because I promise you, if we could, it would be changed. And so I just want to end by asking the entire conference to recognize that although what I'm asking is not simple, this is work that I need everybody to join me in, so that one generation from now, we are not still explaining to Black women, like, so sorry that having a baby is like a life-threatening experience. So on that, I want to thank everybody so much for listening to me on my soapbox, but also for doing the incredible justice work that I know everybody in here is doing. And I want to thank the wonderful AMCHP team, and in particular, Jonathan Webb, for making it possible for me to share some of this today. So thank you guys so much. Oh yes, and of course, I just really wholeheartedly want to thank my incredible funders for giving us the opportunity to offer this gift to our community. So thank you.
Zaya, thank you so much. I really appreciate, I'll give you the round of applause that I know you would be getting if we were in person. Every time I hear you present, I learn something new, and I always feel challenged to go do something more, which I know in our conversations and leading up to this was one of the things that you and I were collectively wanting to hopefully challenge others to do as well. So there have been a ton of questions that are coming through the chat box. I have a couple. I think we have time for 2 or 3. I don't want to cut this conversation short at all. We will have opportunities throughout the course of this conversation to have the states provide a reaction. But just a couple of quick questions here. So one, we have talked, or AMCHP has looked at ways that we have been part of the problem. And you talked about how it's important to engage the community and censor their voice. But some of the challenges that we have learned, and I'm speaking for AMCHP, but I know on behalf of others, is that sometimes the states, sometimes organizations like ours aren't always seen as allies. So from your perspective, how could an organization who is really interested in doing this work, taking your charge and moving forward, how could first, how have you seen from your experience these organizations be perceived, and then two, how do we then meaningfully engage community members? The Women in Infant Health team that we've been working with, they talk about progress at the speed of trust. That trust building is important. So what thoughts could you give in terms of the perception and in terms of suggested next steps on how to build that relationship?
Yeah. I mean, as far as the broken trust goes, just the fact that we have been looking at these health disparities since the 80s, y'all. Like, there was a national report that called out racial health disparities in this country in the 1980s, and we have made almost no progress since then in closing those disparities. So as a Black community, I don't know how we're supposed to trust our institutions that to believe that they have our protection and our well-being in mind when they leave us out there so unprotected for so long. So that's the first thing I want to say, is that it's hard to trust institutions because institutions haven't been trustworthy with us. As far as building the trust, one of the things about racism that's really hard is it severs all of our humanity. And it severs our ability, our natural human ability to be relational with one another. You know, like, I can say for myself, even like in San Francisco, we have a very intense and visible homeless problem. I don't know if y'all have seen, but we get written up in national newspapers at least once a month because it's really deep. And since COVID, it's gotten even more intense. And I'm sure this will probably not be surprising to most folks, but despite the fact that very few Black people still live in my city, overwhelmingly, the folks who are experiencing homelessness are Black. And there's this way in which I have become desensitized to Black homelessness. I can walk out of my grocery store and see multiple people who are like visibly suffering terribly, and I can keep my day moving. And that's a disruption in being relational. And I personally think that my own socialization around how I personally have been taught through this culture to perceive my own folks makes it hard for me to stay in relationship and fully see some of these people as human. And that is because of racism. It breaks our ability to be in relationship. So I guess I would say, like, in terms of building trust, if your sister or your cousin or your good friend did something and it violated your trust, what would you have to do to rebuild that trust? Because all this is about relationship building. And what you would have to do is A, take some authentic accountability for the ways in which you were foul, probably, right? And B, you would probably want to validate the harm that your foulness has caused, right? And then C, you want to offer an authentic apology. None of this, like, I'm sorry if you were offended, but like an authentic apology. And then you make repair. And repair looks like doing the work how it should be done. It looks like some of the reparations that I was talking about. It looks like honoring the expertise of community by not just bringing them to the table, hearing their suggestions, and then doing whatever you wanted to do anyways, but actually centering their ideas and valuing their expertise and paying for their expertise. So to people who have some trust building to do, and I would assume that's most of us, I would just offer that in the same way if you violated somebody's trust personally, you need to take those same steps to heal with that person. That's the same steps you need to take with community. And in doing that, we're fighting racism and restoring our humanity.
Thank you so much, Zay. I'm going to take one from the chat box. So there's an overwhelming amount of support for you in this topic and the way you framed it, the historical context and looking at the past to figure out where the mistakes were and challenging to move to the future. So there's an overwhelming amount of support for just your approach and your thoughtfulness in laying this out. One of the questions is, yes, thank you. Can you share some examples of state policies or laws that you'd recommend or that you have seen to be successful in reducing racial disparities? And are there policies that you would recommend that address root causes beyond reparations?
Yeah, I think that there's a ton. I mean, me personally, I think that any laws that are looking at how we can eradicate poverty are super important. Like, the minimum wage in most states is not a viable living wage. And so the work that we need to do around making sure that the minimum wage is a viable living wage, to ensure that gig workers have adequate benefits, to ensure that all communities have access to high quality jobs, like that kind of work is essential. And we know that economic justice is deeply related to educational justice. And so any kind of policies that also expand opportunities for marginalized students to be able to access high quality education is also really important. For me, what I feel like is actually a low hanging fruit is Doula Care. There is a ton of research that shows that having a doula, and specifically having a doula from your same community, is something that can really reduce the risks of adverse birth outcomes, but also can provide like beautiful birth experiences. But unfortunately, most marginalized folks can't afford a doula, so they can't even afford this protection that is so accessible. So we in California actually introduced, Expecting Justice got to help lead a statewide coalition that introduced AB 2258, which was going to be a bill that had Medi-Cal cover doula care. Rona was like, get out of here with all that. So we're hoping to reintroduce in a couple of years when California hopefully has money again. But I think that looking at how we can expand access to doula care is something that we should all be working on, because that is something that will yield results right away. But again, we can't just have short-term solutions. And so really doing that deep upstream work around fighting racism, criminal justice, voting rights, educational justice, economic access, like all of these things are the kind of legislative work that we need to do. Lastly, I would say that parental leave rights are so important, and they're important not just for healthy birth, but for healthy children, because I'm a pediatrician, and people who are experiencing racial marginalization, like, we don't have the opportunity to bond with our kids in the same kind of way because we don't have the financial resources that we need to be able to stay at home. And so paid parental leave is so important for all of that. So those are some suggestions, but there is any number. And I just want to lift up that Black Mamas Matter Alliance. If you Google them, they actually have a pre-made policy platform that any birth justice advocate could start to implement right away. And they're not the only ones, you know, Sister Song, Black Women for Birthing Justice. There are any number of organizations around birthing justice that can also help people lay out a solid policy agenda.
Thank you so much. I do want to, I know we're running a little bit long, but it's an important topic. So I do want to ask one other question, because you touched on this earlier, and even in your responses, and I just want to make sure that you have a chance to speak to it. The weight of this, although this is a problem that impacts people of color, the weight of this is not solely on our shoulders. And I know there are a lot of folks who are interested, who are allies in this work, who are really committed to rolling up sleeves and working alongside communities of color and doing this work. But you talked about a really important approach to doing it in a way where that voice is centered and not being paternalistic and not have a savior mentality and those kind of things. How would you encourage or invite allies to get involved in this work in a way that is respectful of the history that you just outlined? If people are coming into this at different places and aren't necessarily as astute in the history, like, how would you invite others to sort of get in the game or advance the cause even where they are?
Well, I think I would start with just inviting others to get in the game. I mean, to be quite frank, I think that we all, but in particular people who experience racial privilege in this country, need to take some accountability for the fact that we are not very far along. You know, I, in my pediatric role, sit in the clinic with these Black and brown children, and it breaks my heart that this is the world that they are inheriting. And it's not fair. So we all got to get in the game. And I think that I will just speak for myself that as a Black woman, I am carrying so much emotional stress in this very moment. It is so heartbreaking to be a Black doctor and see these COVID disparities in real time. It is so heartbreaking to be a Black pediatrician and see these families trying to figure out how to keep their kids fed when they don't have a job anymore. It is so hard, and so I'm carrying a lot of weight. And so what I would ask of allies is to step lightly, recognizing that we're carrying a lot of weight. We need you to be really conscious with your words and your actions, because it's so much already that Black women, ideally, when working with allies, shouldn't have to also carry the weight of their allies' ignorance. So get educated about what it looks like to be a respectful ally before you step into the work, and don't let your fear of not being a respectful ally being an excuse for not stepping into the work. A lot of times people say, how do I learn more? What do I do? And I always, when people ask me that question, I always say, well, if you had a fruit fly infestation in your home, what would you do? How would you figure out what to do? And people always say, I Google it. There are incredible resources on Google right now about what it looks like to be an excellent ally and how that looks. And so I would just encourage everybody to get super educated so that we don't accidentally put even more emotional burden on people of color. What I would also say is that, you know, in this country, we have a very long legacy of white people in particular being in charge. It just is how this country is formed. And when you look across our institutions and our businesses, that is really how our country continues to be run. And so I think that a lot of people, just because how we have all been socialized in this country, when white people step into movements, a lot of times there might be an unconscious perception that they're going to move into leadership. And so as an anti-racist practice, I would encourage people who are of racial privilege to practice what is it like to be a part of a movement where you are not in charge. What does that feel like? Try it on. That is part of the anti-racist practice. One of the ways that we hold ourselves accountable at expecting justice to not be in charge, because even though we are a Black-led institution, we are also, you know, institutionalized. We are part of the San Francisco Department of Public Health. So we still have to hold ourselves accountable for centering community voice and not institutional voice. And one of the ways we do is through something that we call the expert opinion. On all of our work groups and steering committees, we have paid mamas sitting on them. And we never take a major vote or make a major decision without soliciting what we call the expert opinion. And what that is we invite all of the mamas on the steering committee to give their final perspective or opinion on how they think people should vote and why. And nobody else is allowed to rebut them, because what we noticed is that at first the mamas were not speaking up in these settings because it was so overwhelming to say a perspective and then get argued down by like the CEO of a major health insurance company who's also on our steering committee. And so we have a practice now where they get the last word, nobody gets to argue them, and that is the last thing that you're hearing in your head when it's time for you to make a vote. And by having that practice in place for every single vote, at the very least, we're holding ourselves accountable to some degree of centering community. So what I would offer people is please steal that idea, please make sure that you have community members on the decision-making body, make sure that you are letting community members of color actually hold decision-making power, make sure that you're compensating them for their expertise, and do your research ahead of time to see if there are community of color-led groups that are already doing the work that you can join with, but follow their leadership, and B, do your work around what it means to be a conscientious and helpful ally. Did that answer it?
That's perfect. That's perfect. Thank you so much, Zaya. I really appreciate your time today. Your thoughtfulness, the just taking us through that journey and giving us some concrete action steps. I will say for folks on the phone and who are with us virtually, the platform that we have will allow us to respond to a number of the questions that are in here for your viewing later. So I'll work with Dr. Malawa offline to answer some of those questions, have them put into the chat box, and then you can go back and revisit the responses that we are unable to get through Dr. Malawa. Thank you again, Zaya. Really appreciated everything this afternoon.
Thank you so much. And to everybody on the conference, I want to say, go out and give them health.
I love that. I love that. Well, I'll turn it back over to Dr. Payne. Thank you so much again, Zaya.
Thank you so much, Dr. Malawa and Jonathan, for that question and answer, but we really do appreciate such a thoughtful presentation from you, and really just provoking thoughts for all of us at this time, and really that all the efforts that you're doing and you're making really to further and advance equity. To all the rest of you, we do plan to continue this discussion throughout the conference. For those of you who want to dive deeper, we will be having 2 networking sessions on this topic on Wednesday, August 5th at 11:45 a.m. and Thursday, August 6th at 2:45 p.m. So please be sure to join those. Now I have the privilege of presenting awards to legislative champions who have worked tirelessly to bring equity in MCH. We are now pleased to hear from this year's 3 distinguished legislative champion for MCH award winners, Congresswoman Lauren Underwood of Illinois and Congresswoman Alma Adams, who are recognized for founding the Black Maternal Health Caucus and introducing the Black Maternal Health Momnibus, as well as Congresswoman Susan Brooks of Indiana, who is being recognized for co-leading efforts to support increased Title V funding, as well as introducing the Data Mapping to Save Moms' Lives Act. Here is a short video with their remarks.
Hi, everybody. It's Congresswoman Lauren Underwood. I just wanted to thank the AMCHP Board of Directors and all of the members for this incredible award. I am so honored to be recognized alongside Congresswoman Alma Adams, who's my partner and our co-chair for the Black Maternal Health Caucus, and then also to Congresswoman Brooks, a true champion for moms and babies. These are such challenging circumstances in our country right now, and I know that the work of AMCHP members are so important to the lives of families across our country. Literally, women, children, and families rely on you every day, and your voices are so critically important here in Washington. We are so grateful to have you as thought partners and resources as we continue to advance our Momnibus bill, the Black Maternal Health Momnibus Act, and the 12-month postpartum Medicaid expansion. Thank you for your partnership in developing this legislation, your advocacy to build momentum so that we can get these things passed and signed into law. I really hope we can get together in person one day soon. But in the meantime, please continue to take good care of yourselves, okay? And enjoy the conference. Thanks so much. Bye-bye.
Hello, everyone. Thank you for the Legislative Champions for Maternal and Child Health Award. I'm truly honored to be recognized by the Association of Maternal and Child Health Programs. Your work to improve the health of women and children is critically important. As a proud mother of 2 and a member of Congress working on behalf of Hoosiers, our country must do better to ensure expectant mothers all across the country have far better access to health care. We know that women in rural areas often suffer the most, which is why I introduced legislation to use data mapping to identify areas of the country where high rates of poor maternal health overlap with a lack of broadband access. I'm also proud to be on the House Energy and Commerce Committee, where we have been focused for quite some time on bringing attention to the issue of maternal mortality. Our committees held many hearings on maternal health issues, and last year we passed a number of bipartisan bills to address this crisis. But there is still so much more work to be done. If it wasn't for groups like you, Congress wouldn't hold such hearings or pass life-saving legislation to address maternal mortality. So thank you again for your grassroots efforts of educating my staff, educating me on this issue, and for your advocacy, most importantly, on behalf of the health of mothers, children, and families all across our nation. Thank you. I'm honored.
Hello, everyone. It's a pleasure to be here virtually with all of you. First, let me say that it is an absolute honor to receive this year's Legislative Champion Award for Maternal and Child Health. I am thrilled to be selected alongside my colleagues, Congresswoman Lauren Underwood and Congresswoman Susan Brooks. I want to thank AMCHP's Board of Directors and all of the members for this award. In particular, I want to give a special shout out to Belinda Pettiford and all of the North Carolina members. Thank you for the work that you do day in and day out to ensure moms and babies across the country have access to quality care and remain healthy. During COVID-19, the work of protecting the health of our mothers and infants has come into sharper focus, and Congress must continue to do all that we can to promote improved maternal and child health outcomes. With AMCHP's leadership and support, I pledge to continue making this issue an absolute priority. And as many of you know, I've been fighting in Congress to elevate one of the major public health crises of our time, Black maternal health. For me, this is a deeply personal issue. My focus on Black maternal health began when my daughter survived a complicated pregnancy that almost claimed her life. So last April, Congresswoman Underwood and I launched the Black Maternal Health Caucus to develop and advance evidence-based policy solutions to the issues impacting maternal health. We wanted to raise awareness, educate our colleagues, and shine a spotlight on the maternal health crisis, mothers needlessly dying during what should be one of the most joyous times of their lives. Our caucus has since grown to more than 100 members, which speaks to the importance of this issue and how it resonates so deeply within Congress and across party lines. Earlier this year, we introduced our first major proposal, a comprehensive 9-bill package called the Black Maternal Health Momnibus Act. And I'm proud to say that AMCHP has been with us from the very, very beginning. I can't thank you enough for your dedication and commitment to these issues. I look forward to continuing to stand with you to protect moms and babies. Thank you again for this incredible honor, and best wishes for a successful and productive conference.
Thank you so much for your legislative leadership. Last but not least, I'm excited to present the Go Beyond Award to 3 deserving graduate students in MCH. This is the 8th year that AMCHP has partnered with Go Beyond MCH to offer this scholarship. This year, we have added another scholarship sponsor, Johnson & Johnson. Thank you both for your generosity in supporting graduate students and furthering their education and providing professional development opportunities for these young leaders. We had a very competitive group of candidates, but we have selected 3 winners. Our first winner is Rochelle Logan. Rochelle is a public health professional with over 13 years of practice-based experience analyzing the factors that influence health outcomes in underserved communities. She received her Bachelor of Science degree in Community Health Education and a Master of Public Health degree from the Morgan State University School of Community Health and Policy in Baltimore, Maryland. Her current research is focused on dissecting factors within the physical and socio-cultural environment that influences the health and development of low-income children ages birth to 5 years of age in Washington, D.C. Congratulations, Rochelle. Our next winner is Kelly Robinson. Kelly is a certified nurse midwife whose clinical practice has included full-scope midwifery care in a variety of settings, including birth centers, with extensive experience in maternal newborn care under both normal and higher risk conditions. She used her practice and teaching skills to serve as a clinical instructor at the Johns Hopkins School of Nursing, where she is currently pursuing her PhD. Her research examines housing instability during pregnancy and associated maternal mortality. She is passionate about improving health outcomes for marginalized women globally, also serving on short mission trips to Haiti. Congratulations, Kelly. Last but not least, our last winner is Lorenia Mangum. Lorenia is a doctoral student in the School of Social Work at the University of Pittsburgh and is also earning her Master of Public Health in Department of Behavior and Community Health Sciences at the Graduate School of Public Health. Lorenia's clinical experience has centered on promoting optimal health outcomes for underserved minority populations in child welfare, maternal and child health, community health, and community development. She is also interested in the role of social networks and multi-level support systems for Black custodial caregivers living with HIV. Congratulations, Lorenia. Again, congratulations to all of our winners, and thanks again to the Go Beyond MCH and Johnson & Johnson for supporting this scholarship. Please go to the conference website to learn more about these candidates and learn more about their background and their current research areas. And now, to close out the plenary, I'll turn it back over to Jonathan.
Thank you, Shirley. I have the privilege of closing out this session, and I'll be very brief because I know we're running over. But I hope you've had a chance. I hope you've enjoyed the session, and that you have learned something new that you can apply in your respective areas, and you feel challenged to identify solutions that are long-term, that are precise, have a precise impact, that look at system change and explore reparations in an innovative way. And again, thank you to Dr. Malawa for her challenge, her charge, and for walking us through all of that very thoughtfully, helping us to understand the past so we can change the current and look to the future in a different way. As Shirley was mentioning earlier, as I mentioned earlier, we really appreciate the support of all of our sponsors and exhibitors. So we invite you during this time to go take a look at their booths, visit them at their virtual booths before you leave us. They've got a ton of great information and resources that we'd love to share with you. I really appreciate your sticking with us, your being with us today, your coming out today, and your commitment to being with us over the next few days here. I look forward to seeing you tomorrow for round 2. We've got another great session of workshops, another great plenary, a number of great poster sessions there. So please make sure that you join us tomorrow and take the time to visit our exhibitors and our poster presenters. Thank you so much and have a great rest of your day.